This is an example of a combination technique that can be used in the management of tennis elbow. The two techniques involved are a fascial technique to the lateral epicondyle, followed by a muscle technique to the common extensor muscles. This is a fascial taping technique applied to the epicondyle of the elbow joint, used to gently reposition the fascia so as to improve function. First, note if there is pain and/or restriction of movement during various pain provocation tests. Actively flex and extend the elbow joint. Actively extend the wrist against resistance. Actively extend the ring finger against resistance. Repeatedly clench the fist. A small myofascial glide is performed in order to hold the fascia in the desired position. Because of the multidirectional nature of the fascial tissue, the myofascial glide assessment may be performed in more than one direction in order to achieve the desired outcome when carrying out the pain provocation tests. The final decision is determined by the most effective glide. In this example, freer movement is experienced through an upward myofascial glide. Therefore, the base point is positioned at 3 to 5 centimeters beyond the tip of the olecranon process of the ulna bone, where the tape splits into a Y. Each tail extends upwards and beyond the lateral epicondyle, at which point they converge. Mark the base point. Place a second mark over the lateral epicondyle. Place the patient's elbow into maximal achievable flexion. Measure the tape from the base point to the lateral epicondyle. Cut and prepare a Y-strip. Peel back 3 to 4 centimeters of tape and apply the base as an anchor. Further stretch is achieved by flexing the wrist, adduction of the shoulder, and side flexion and rotation of the neck to the opposite side of that being treated. Tear the backing paper and gently peel it off from each tail, leaving a 1 to 2 centimeter tip at each end. Hold each tip and apply 25 to 50% stretch to each tail and simultaneously lay down the first 3 centimeters of tape. Apply 25 to 50% stretch again and lay down another 3 centimeters of tape. Repeat a third time in an oscillating action. The ends of the tails converge. Within the boundaries of each tail, the fascia is repositioned in the direction of the tail ends. This completes the fascial technique to the lateral epicondyle, or the first application of the combination technique. Repeat the same pain provocation tests as before. In this example, the outcome of the pain provocation retesting has shown a reduction in epicondyle pain, but with continuing presence of forearm muscle belly pain. This has determined that an additional technique is required. This will be a muscle taping technique to the common extensor muscles. Position the shoulder in 45 degrees abduction and the elbow in 90 degrees flexion with palm facing downwards. This muscle taping technique is applied to the 4 common extensor muscles: extensor carpi radialis brevis, extensor digitorum, extensor digiti minimum, extensor carpi ulnaris. This precipitates the lifting and repositioning of the underlying tissue, which should result in increased wrist flexion. The base point is located over the lateral epicondyle. The tape extends distally to the heads of the first 4 metacarpals. With the patient in neutral, mark the base point on the lateral epicondyle. Mark 2 endpoints over the knuckles of the middle and ring fingers. Measure the tape to the end points. Cut and prepare an eye strip to the appropriate length. With the patient's arm, wrist and hand in neutral, lay down a 3 to 4 centimeter base of tape without tension as an anchor. Fully extend the elbow and maximally flex the wrist. For further stretch, move the shoulder into extension. While in this position, peel away the backing paper and smoothly lay down the eye strip to the end point with absolutely no tension. Return the arm, wrist and hand to neutral. Look for convolutions when flexing the wrist. Repeat the pain provocation tests. The patient should experience immediate improved wrist flexion, extension, and localized pain relief. If the patient does not experience relief of symptoms, check the tape has been correctly applied or reconsider the chosen combination of techniques.